Okay, thank you very much. Good morning. I have to address two topics, chronic pancreatitis and IPMN. I will start with chronic pancreatitis as usual. So first thing I would like to emphasize is that chronic pancreatitis is an immunomodulated disease. Indeed, any patient with chronic pancreatitis adds in his past medical history an acute pancreatitis event. This has been defined many years ago by this concept of SAPE, Sentinel Acute Pancreatitis Event, which is an important one because it also means that we cannot predict in a specific patient the evolution of the disease. It's a very personal disease in each case. In the natural history of alcoholic chronic pancreatitis has already been defined many years ago. You may have patients that after a first attack of acute pancreatitis driven by an oxidative stress or alcoholic injury may evolve progressively to the end stages of chronic pancreatitis with a huge amount of fibrosis, calcifications, ductal involvement, irregularities, obstruction, or in many other cases, these patients may resolve spontaneously. Just an example here I can show you. So this is the first MR imaging in this peculiar patient. You see that the main pancreatic duct is intact. You have clearly acute pancreatitis changes in both in the pancreatic parenchyma and in the peripancreatic environment. And the follow-up of this patient is like in the previous diagram I showed you. The patient develops collections, and finally these collections will resolve with the development of pancreatic atrophy, ductal dilatation, and fibrosis. So this is the common and the most common natural history of alcoholic pancreatitis driven in specific patients and leading to chronic pancreatitis. Now, which imaging technique should we apply to investigate this entity? Indeed, the imaging technique depends on what we want to see. If you want to look for calcifications, which in reality provides the best diagnostic confidence, at least up to 90%, you may use plain films. Of course, no one is using that anymore. ERCP is a very good technique, but no one is using ERCP anymore for diagnostic purposes. And of course, CT and MDCT is the best modality available nowadays. If you want to look at the parenchymal changes, CT and MRI perform more or less equally well. If you want to look at the ducts, clearly MRI is the leading technique nowadays, and as I mentioned, ERCP, although it's a very high-resolution technique for examining the ducts, has a high morbidity associated, and it's no more used for diagnostic purposes. The exocrine function may be important, although it's not used nowadays in the majority of the centers. And for this, you may use indirect tests, which are not very good for that. You may use the secretin test, which is quite invasive, and MRI, again, may be used to address the secretion, not exactly the function, because you cannot measure bicarbonate with this technique. And finally, for complications, which is probably the most important goal when using imaging for this kind of disease, may be addressed again by both either CT or MRI. So just a few examples. MRCP and MRI is not at all a good technique for detecting calcifications. We have just an example here. You can detect them very nicely on MDCT with the reconstructions. And on MRCP, if you are not aware of these specific and subtle signs, you just have a decrease in signal intensity on the ducts in the head of the pancreas in this particular patient, and you may see quite nicely the ductal obstruction. Just another example, at MRCP, you can detect very nicely these calcifications if they are surrounded by fluid, and the calcifications are, in the majority of the cases, always intraductal. Now, just a specific word concerning hereditary chronic pancreatitis, because these patients develop what we could call calcifications. Indeed, these are not calcified stones. They developed mainly protein plug like stones, and these are not calcified, and we can miss them very, very rapidly and very often with any of the techniques, either CT or MRI. And in this specific setting, ERCP still has some diagnostic advantages, and is the best technique to display and to cure the patient. Now, pancreatic parenchyma alterations are very well known. You may have atrophy changes along with ductal dilatation and the presence of calcifications that may be obstructive or not. This can also be addressed without contrast enhancement at MRI, and this is already a very old scan, but you can see here that on T2 weighted imaging, you have no chance to detect this fibrotic component of the parenchyma involvement, and for that, T1 weighted imaging is much, much better, since the pancreas will lose the normal hyperintense signal intensity, which will be displayed in these sequences. You can use contrast enhancement for addressing parenchyma alterations, and you see quite nicely in this particular case that there is an ischemic event at the origin of the pancreatitis itself. You don't have anymore the blush that you should have when addressing the pancreas in the arterial phase. Although in the delayed phase, you have a normal enhancement, which is more or less related to the amount of fibrosis. Concerning ductal involvement, indeed, MRCP and MRI will fit quite well with endoscopic classification, with the exception of this type 5 chronic pancreatitis, which doesn't exist on the MRI side, since we can detect ductal changes all along the duct, even if you have an obstruction which is distal to the duct itself. But clearly we can discriminate type 1, 2, 3, and 4 chronic pancreatitis changes involving the ducts. In the initial phase, ERCP certainly is the best technique, but as I mentioned, we don't use that anymore, and MRCP is much, much better than CT for evaluating the first changes of chronic pancreatitis, the first involvement of the ducts in chronic pancreatitis. And the amazing story is that although chronic pancreatitis is a parenchymal disease, if you are in the early stages of the disease, and if you have the possibility of using contrast-enhanced MRCP with secretin, like in this case here, you can detect these early changes and these subtle dilatations of the collaterals, some bulging of the collaterals here, although the parenchyma itself is normal. This has been addressed in very, very few papers. The most recent one is this one in the World Journal of Gastroenterology, using this technique with a 92% specificity for the detection of the early phases of chronic pancreatitis. With MRI and secretin stimulation, you have the possibility nowadays of addressing the secretory function, and you have just an example here, before and after secretin stimulation. This patient has a normal function. You can determine the total volume excreted and the output of the secretion. Although the patient has severe disease with a ductal dilatation and obstruction of the main pancreatic duct, still the exocrine function is preserved, which may be important when selecting patients for specific therapies. But probably the most interesting situation to be addressed by the function itself are those patients which present with atrophy without any ductal alteration. And indeed, in these patients, if you address the exocrine function with either technique, you can discriminate between atrophic changes with normal ducts from the normal population with a good significance. Now, complications, as in acute pancreatitis, you may have collections and pseudocysts. These occur quite often in chronic pancreatitis. The most important thing is to look at the ducts and also at the vessels, because in the many situations, you see here that splenic vein thrombosis and portal hypertension are a very common complication of chronic pancreatitis, and also this has a huge impact when trying to select patients for therapy, and particularly for surgery. Bile duct stenosis may occur in 3 to 45% of the cases, and still the major dilemma, which is not solved at all, is the differential diagnosis with cancer. We know that there is an increased risk of cancer development in chronic pancreatitis patients, particularly those who are still smokers and in the hereditary forms. Still, we should remind that a space-occupying lesion in the setting of chronic pancreatitis is benign in 5 to 11% of the patients. Just a few examples here. You have this fluid collection in the tail of the pancreas. Without hormonal stimulation, you have a gap here in the main pancreatic duct. So this is important. This is a disconnected duct with a collection in the tail. But if you inject secretin, you can solve this problem very elegantly. And this is important for the endoscopic management of these kind of situations. Another example, which is a very complex one, of a patient that presented to the emergency room with a pleural effusion, and indeed this pleural effusion was related to a rupture of the pancreatic duct in the tail, and you can nicely see here the pathway of this fistula and the filling of the pleural effusion from the pancreas itself. Another example demonstrating the rupture using secretin stimulation again. Here in the tail of the pancreas, you have this large collection in the tail of the pancreas. You have a much brighter fluid collection inside the larger one. And when you inject secretin, you see that this small amount of fluid that is very bright increases in size and increases in volume, which means that you have a fistula and a leakage at that point. And you can also address that by using cross-sectional imaging, using exactly the same sequence like here, before and after secretin stimulation, and you see quite nicely the site of the rupture of the leakage and the increase in volume of the fluid collection itself. We can also address infection. Of course, if you have gas at CT, infection can be suspected with a very high confidence level, but in the majority of the patients, you don't have gas inside. And nowadays, we are using diffusion-weighted imaging to address this question. And indeed, we have quite nice results in the first patients we examined by looking at the ADC. And if you fix the threshold of the ADC around 0.09, you have a very, very high sensitivity and specificity for diagnosing infection. This is just an example in two different patients with more or less the same kind of collection, and you see that the collections are very bright on T2, so you don't have any precursor sign of infection on these cross-sectional imaging studies. And if you address that with diffusion-weighted imaging, I am presenting on here the hybrid imaging, you see that in one patient you have a very low ADC associated with the collection, although in the other the ADC is normal. Vascular complications, as I mentioned, are relatively common. You may have pseudoaneurysms, and this should be addressed if any of these collections is addressed for endoscopic treatment. You have very, very often portal vein thrombosis, splenic occlusion, and segmental portal hypertension with huge varices, like in this patient with a large amount of calcifications and a diffuse involvement of the pancreas. Bile duct strictures, as I mentioned, are quite often observed, but indeed for the clinicians, the majority of them are clinically silent, so they don't take care of that. If the patient presents with cholangitis or with jaundice, of course, you have to address this question, and in the majority of those patients, they will be sent for endoscopic drainage. Now, associated malignancy is a huge challenge and a dilemma still nowadays. What I would like to mention here is that in the setting of chronic pancreatitis, if you have a mass lesion and you use endoscopic ultrasound FNA, the sensitivity is only 50%, which is not the case in non-chronic pancreatitis situations. So recently, in this paper, a prediction rule for estimating the risk of pancreatic cancer in the setting of chronic pancreatitis was developed. You have many variables: the gender, the mass localization, the number of lesions, the direct bilirubin, and the tumoral markers. So concerning radiology and imaging, we have to detect this mass, which is not that trivial. So if you have a mass, you have two possibilities. Either nowadays you can use contrast enhanced CT or MRI, or diffusion-weighted imaging, or both. And you have to look at ductal obstruction, ductal strictures, and for those who may use secretin stimulation, this is a very elegant technique to discriminate both entities. Just an example here in a very, very young lady, 35 years old, with chronic pancreatitis changes. You see that the common bile duct is not dilated, although we have a small interruption, or at least a stricture, or what could be a stricture at this level, but no one paid attention to that, and 2 months later, this is the situation. The patient came with jaundice, and now we have clearly a mass in the head of the pancreas responsible for a Santorini duct stricture and a common bile duct stricture. And indeed, this mass was already there if we look retrospectively to this MRCP, but you should certainly agree with me that this is a very difficult task. Now we can use contrast, but indeed it's helpful in some instances, but not in every instance. So this paper on 48 patients with different kind of tumors and inflammatory conditions tried to discriminate those. And the type 4 curve, which means a progressive enhancement of the pancreatic parenchyma or the mass, was majorly seen in the majority of the patients in adenocarcinomas. Still, the most important thing is to combine and to do some kind of multiparametric imaging. So here you have a stricture, but no ductal dilatation. You have a mass in the uncinate process, which is hyperintense. You inject contrast. In the arterial phase, it's hypovascular. In the delayed phase, it's hyper-enhancing compared to the normal parenchyma. And this was a focal form of pancreatitis. Can we use perfusion-weighted imaging to discriminate both entities? Indeed, not really, because both ductal adenocarcinoma and focal chronic pancreatitis have a large amount of fibrosis associated, and indeed the permeability and the perfusion fractions are more or less identical in both situations. Can we use secretin enhancement? Well, in some instances, yes, it's interesting, particularly if you have a stenosis without a space-occupying lesion. This is just an example. At the RCP, it's a very, very old case. You have a stop at this level, so there is clearly a suspicion of ductal obstruction and maybe a pancreatic cancer. At MRI, you have an increased volume of the pancreas at the level of the body. You have a large stricture at this level at MRCP, but again without ductal dilatation or a relatively lack of ductal dilatation upstream. And if you inject secretin, you can preserve the continuity of the stricture itself and also of the collaterals that you can see quite nicely branching on the main pancreatic duct. So like that, you can more or less address this difficult problem if you can feel the stricture, but for that the patient needs to have preserved exocrine reserve. Can diffusion-weighted imaging with the normal and the usual technique of 2B values solve this problem? Indeed, just two examples here, which are more or less identical. You have the same degree of ductal dilatation. You have a mass in the head of the pancreas. In this particular patient, the mass looks like more desmoplastic and even invading the vessels. On diffusion-weighted imaging, you have more or less the same amount of restriction. And indeed, these two patients were operated, and you have a chronic pancreatitis case and a pancreatic cancer. So just by using that, it's not enough. Recently, in radiology, this Korean team published the first robust data using a bioexponential model for diffusion-weighted imaging. And you see again that ADC, the ADC measurement alone, do not allow us to discriminate pancreatic cancer and chronic pancreatitis and even neuroendocrine tumors and the normal population. But if you address this with the IVIM model and you measure the perfusion fraction, clearly they could find a significant difference, a statistically significant difference between pancreatic cancer patients and chronic pancreatitis. So probably we have here a tool that should be investigated in many other centers to address this question. Just an example from our own in a patient with a pseudotumor in the uncinate process, and you see that the perfusion fraction here is about 15%, which is more or less in the range of the inflammation provided by the Korean authors. Shifting to IPMN, very quickly, there is a consensus definition from 2004. This is a gross visible epithelial lesion, predominantly papillary, rarely flat. You have a variety of cell types in this entity. The most important thing is that you should have mucin producing. The disease may affect the main pancreatic duct or the branch ducts, and you have varying degrees of ductal dilatation. Just two different examples here. You have the papillary proliferation, the ductal dilatation, and the important thing here, and this is just the take-home message for you, is that you have no stricture on the duct side associated with these lesions, since the disease is inside the duct. So we have an expansion of the duct itself, which is represented here in this pathological specimen. It's a very common disease if you are addressing cystic neoplasms of the pancreas. Indeed, IPMNs and serous cystadenomas are the most frequent cystic lesions, along with mucinous cystic neoplasms. You have of course, this stepwise evolution from hyperplasia to adenocarcinoma, particularly when the lesions involve the main pancreatic duct. Just a few examples here. This is a main duct lesion. This is a combined tip lesion involving the main duct and the branch ducts. A very small lesion, and again a smaller lesion here related to the ancinate process duct in the head of the pancreas in a branch duct type. Now, why is it important to discriminate both entities? This is mainly related to the occurrence of invasive carcinoma and carcinoma in situ, which is much more common in the main duct type. And of course, according to that, the 5-year survival rate is significantly different between entities. What is the role of imaging? Well, to make the diagnosis, and for that we need to look at the morphology of the pancreatic ducts, to identify predictive factors of malignancy, and the main factor is the mural nodule, and you have to look at the ductal content, and for follow-up. Now, for the main duct type, as I mentioned, the most important thing is that in the majority of the patients, if you want to do the differential diagnosis with chronic pancreatitis, you have no strictures and you have no calcifications. We should detect the nodules and look at mucin by looking at a filling defect. Just an example here, comparing CT, ERCP, and MRCP. You see that the ERCP and MRCP images are quite similar, although ERCP has the advantages of providing the diagnosis of the mucin content and also has the capability of addressing the mural nodules and performing a biopsy in the intraductal content. Just another example that emphasizes the fact that you have no stricture, you have a huge dilatation of the duct, and suddenly you have a discrepancy with the downstream duct, but without any stricture explaining this huge dilatation, since the disease is inside the duct. And when you have a huge amount of mucin content, at ERCP it's quite difficult to assess the complete extent of the lesions themselves. So the main duct type challenges are the differential diagnosis with chronic pancreatitis and to detect malignant transformation. And for this, probably the best technique is endoscopic ultrasound with guided biopsy, 91% sensitivity in this specific study if a solid nodule is present. So just examples of differentials. Here you have a main duct type with no stricture at the lesion level. You see that you have changes, morphological changes that mimic chronic pancreatitis changes. You have ductal dilatation, you have an atrophy of the pancreatic gland itself. But if you turn around these ducts, you see that there is no stricture at all explaining this segmental dilatation at the tail of the pancreas. Predictive factors of malignancy. In this multivariate analysis, you see that mural nodules, jaundice, and the main duct were the best predictors of malignancy. So just an example here in a very, very old patient with obstructive bile duct by this huge stone, and this was an incidental finding of a dilatation of the main pancreatic duct. ERCP displayed the mucin itself, but could not find this very, very small nodule that was displayed at endoscopic ultrasound in this cystic dilatation of the main pancreatic duct here, and the biopsy at this level provided an invasive adenocarcinoma, which was an incidental finding in this particular patient. Another example is the use of diffusion-weighted imaging when you have these large lesions to detect the solid components and to predict for malignancy. This is a very nice example of the involvement of the main pancreatic duct with this huge solid nodule and associated diffusion restriction. Now you have differentials with these masses, intraductal masses, and this is a very elegant example which mimics IPMN. Indeed, you have a mass, you have ductal dilatation. When you inject contrast, the mass is hypervascular on CT and on MRI. And on diffusion-weighted imaging, you have restriction associated. What is lacking in this particular case is the distension of the duct where the mass is present, because you have no mucin production associated with this lesion, which is an hypervascular lesion. This is very uncommon. There is no mucin production and lack of main pancreatic duct dilatation at the level of the nodule. And indeed, this was a neuroendocrine tumor only limited to the main pancreatic duct. For the branch duct type, the most frequent location is the uncinate process. The key feature that is still a challenge is to determine the communication with the main pancreatic duct. And again, as for the main duct type, we have to detect predictive factors of malignancy. So CT and MR perform more or less equally well when the lesions are quite big, and when you have a dilatation associated of the main pancreatic duct, the display of the communication is very, very easily demonstrated with both modalities. Of course, with MR, you don't need to inject contrast. But when you have very distal dilatations and you need to assess the communication, MRI performs much better than CT and even than ERCP. Here you have two different patients and the corresponding images, MRCP and ERCP, and you see that the display of the full extent of the lesion is much better at MRI. The challenges, the demonstration of the communication, again, the differential diagnosis with chronic pancreatitis, the detection of malignancy and multiple lesions. Just an example here, this is very difficult. Is there a communication or not? So this patient was operated. Is there a communication or not? This patient was also operated. No communication was observed. And indeed, in this case, this was a serous cystadenoma, and this was a carcinoid tumor. And indeed, you can see here that you have some kind of irregular enhancement in the periphery of the lesion itself. I will skip this one. The predictive criteria of malignancy, again, there is no carcinoma, at least if we rely on this particular paper, in branch duct types that are less than 3 centimeters without mural nodules. Still, this is very difficult because if you look at the guidelines, the prognosis depends on the presence or the absence of an invasive carcinoma in branch duct types. And for the pathologist to make the diagnosis, he should have the whole lesion examined, and this is difficult to address nowadays. Just 3 different examples with patients that had either atypical pain or acute recurrent pancreatitis episodes. The lesions are quite the same at MRCP, and you see this is a borderline lesion, this is a carcinoma in situ, and this is an hyperplasia. So no way of doing the differential diagnosis without looking at the whole specimen. Can we address that? And this is my last slides with analysis of the cystic fluid. From this paper, you see that the CA level and the CA 72.4 have a very, very high negative predictive value, which means that you can use this technique to decide when surgery should be avoided. But still, in this particular patient with this very small nodule that most probably we could follow up instead of doing invasive procedures, he had a puncture. The CA was very, very high, around 10,000, so the patient was operated, and this was a mucinous non-neoplastic cyst of the pancreas. So the take-home points, chronic pancreatitis versus IPMN. The lesions are in the parenchyma here mainly in the ducts. The ducts are irregular, they have strictures and stones. Here there is a dilatation without a stricture, mucin production and nodules. You may have a decreased function in chronic pancreatitis. Generally, the function is preserved in IPMNs. The complications are different. Malignancies in the main duct type is the major complication of IPMN. And concerning the imaging workup, CT still is the first imaging modality for chronic pancreatitis, and MRI is the first modality for IPMN. So thank you very much.